right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight I'm joined by Dr. Hartley Miltchin. Thanks for joining me.
Thanks for having me.
Yeah, absolutely. So you're up there in Toronto, Canada, the Bunion King. So why don't you tell everyone where you're at and how you got involved in foot and ankle surgery, specifically as the Bunion King?
I'm located in Toronto, Canada, to clarify things.
Toronto.
And I'm in my 44th year of a profession I simply adore. I graduated from the school in Chicago, originally trained in traditional hospital-based corrections, uh, but I tended to lean towards MIS, and my mentor was one of the pioneers of MIS procedures. And I've been doing MIS procedures exclusively almost 44 years.
That's amazing. So back then, obviously things have shifted and changed. Well, let's dive deep into how you made it from Chicago back to Canada. Where are you from originally?
Toronto.
Okay, so you're from there, came to the United States, and then went back. Is that fairly common in terms of the medical training transferring internationally, even though it's not really that far away? But does the training transfer? How does that really work?
Well, to be quite honest with you, Canadians and Americans are somewhat different. Most Canadians will go to college, what we call university, locally, whereas American individuals tend to move around. They'll go out of state, for example. When
Hmm.
I was going to podiatry school at that particular time, there were only 5 podiatry schools. There was nothing in Canada. So I
Hmm.
had no choice but to go
Okay,
to the United States.
sure. And so when you came to the United States back then, was there residency or how were things different? Because obviously the profession has changed significantly over this time. Was it more of a preceptorship or you just dove in and had to kind of learn on the go?
At the time I graduated, there sometimes there were residencies. The state would require a residency, or often not, or there was reciprocity. Now, of course, there's a 3-year residency and sometimes fellowships. I did a 3-year surgical preceptorship in office.
Hmm. And what that was fairly common or uncommon at that time to spend that long doing a preceptorship? Were some of them shorter?
Yeah, they varied as far as periods of time, but I had a very strong connection with my mentor, and he wanted me to excel and he wanted me to learn, and I was happy where I was. And then it came to a point where my parents were here, my family was here, my friends were here, and I decided to move back to Toronto, where there was a shortage of podiatrists, and a lot of Canadians didn't even know that there was such a thing as a foot specialist or podiatrist. So I decided to set up shop here in Canada.
So, I think a lot of people listening are interested to understand how the Canadian health system differs from the American health system. Ours is obviously very private health insurance driven, and we do have some cash pay models depending on the area of the country. But how does the Canadian health system differ, specifically how it affects you? Are you part of the Canadian health system or do you do more of a concierge practice? How does that work for you?
Basically, where I practice, it's socialized medicine.
Hmm.
So if you want to go to family doctor or a specialist, it's covered under the socialized medicine.
Hmm.
Podiatry is really not covered under the socialized medicine.
Okay.
So I've never accepted any kind of insurance. I'm purely cash pay. Whereas in the United States, I know that some have no choice but to accept insurance, which is really a struggle these days, or they have hybrid or cash pay concierge practices. And according to me, concierge is the ultimate.
Sure. why do you think that podiatry is not a covered service there?
They don't cover certain professions like chiropractic, physical therapy, podiatry,
Sure.
etc.
I gotcha.
Uh, but the mainstream professions in medicine are typically covered.
I
Of
see.
course, if you want cosmetic surgery, it's not covered.
Right.
That's cash pay as well.
Sure. So if someone wants surgery and they find you and they come to Toronto and they want to have a procedure done by you, is that still done in a hospital? Are you doing it in the office? Are you doing a surgery center? Because if you aren't part of the healthcare system, do they exclude you from their facilities or how does that part of it work?
Podiatrists have never had hospital privileges in the province, or I'll call it a state, where
Hmm.
I practice. They've
Okay.
never had hospital privileges.
Sure.
So, in order for me to do surgery, I had to set up a surgical suite in my private clinic, and it's private pay.
Hmm. Makes sense. So, what does minimally invasive surgery mean to you? When you think, because you've said you've been doing it for such a long time, and some people, at least in America, when we think of minimally invasive surgery, there was a time where some people did it and then it kind of faded away, and now it's making this resurgence. How does that how do you interpret that as someone who has been doing minimally invasive surgery for such a long time, or should I say the whole time? How do you interpret minimally invasive surgery?
Well, you're correct in what you said. It was extremely popular in the 80s and early 90s, and then it faded away. And now there's a huge resurgence, not only amongst podiatrists, but orthopedic surgeons. I know I lecture and teach in the cadaver labs uh, all over the United States, and we get not only podiatrists, but orthopedic surgeons from literally around the world. So there's a real resurgence. And a
Hmm.
lot of the vendor, what I call vendor driven, they call it minimally invasive surgery, but it really isn't what I call the real minimally invasive surgery. And it's vendor driven, it's hospital based. And in reality, in the United States, when you're doing surgery in a hospital, you're making money for the hospital. You're not making money for yourself.
Sure. I mean, that makes sense. So, what in your mind, what makes what you're doing real? Because you said that it's real minimally invasive surgery. What is that? What do you mean by real minimally invasive surgery?
Okay, the way I compared the difference between the traditional hospital based surgery, where I practice, you can have it done uh, under the socialized medicine model
Hmm.
at no cost to you. And that's the hospital based. Hospital based generally is obviously you're going to the hospital,
Right.
typically general anesthesia, perhaps sedation and local anesthesia. I guess it depends.
Hmm.
A tourniquet is used. The incisions are quite long,
Hmm.
usually some sort of internal fixation, metal fixation is inserted, a lot of sutures, uh, opioids or narcotics to control the pain, maybe wearing a cast or an air cast type boot,
Hmm.
perhaps non weight bearing for many, many weeks. And the difference with the real minimally invasive surgery, what I do here in my clinic, number one, I only use local anesthesia. And instead of anesthetizing the entire foot, if I'm only working on the bunion area, that's the only area I numb up.
Hmm.
I I don't make incisions because my definition of incisions is that it's got to be either closed with a suture, a staple, a steri strip, Durabond, whatever you want to close it with.
Sure.
I never use one suture in any of my procedures. That's how small they are. So I don't make incisions. I make small pokes.
Hmm.
I don't use tourniquets, so there's no risk with tourniquet use.
Hmm.
My procedure takes anywhere, well, I'll say on average about 20 minutes. Um, I wrap, I externally fixate my cuts.
Okay.
I don't shave and I don't break. I make cuts to realign the deformity. So I externally fixate with tight tape splinting around the distal half of the foot and usually the hallux big toe
Hmm.
and a surgical shoe, not a boot, but a surgical shoe.
Yeah.
Patients are weight bearing, ambulatory immediately, and I encourage them to stay ambulatory throughout the healing process. I don't prescribe narcotics or opioids. My patients don't need it.
Hmm.
I typically will recommend Advil, Aleve, Tylenol, and the results are incredible.
So let's back up there for a second, because a lot of people are listening are thinking, well, then how do you fix the bunion? Let's go back for a minute. So what's actually happening when you say you're not really making an incision, and how are you actually fixing? What are you sticking in there? What are you cutting? What are you releasing? What are you doing?
Okay, I don't know if you can see this, but I'm going to show you what I'm holding in my hand. Can you see that burr?
I can. It's a little out of focus, but I can see it. It looks like a burr we would use here for MIS surgery. So like a side cutting burr. Yeah.
Okay, that's called the Shannon 44, which is most typically used. So
Yeah.
as long as this tip of the burr can fit into that poke,
Hmm.
I'm good.
Right.
So typically I make cuts and realign it. It's my own cut that I developed
Hmm.
for a surgical neck osteotomy at the first metatarsal. Of course, I also reduce the medial eminence
Hmm.
and I do an Aiken procedure, but I do not fixate with any metals because, as far as I'm concerned, and no one can give me an answer, once there's an osteotomy in a bone, why does metal have to remain there once the bone is healed? Personally, I don't see any reason for it.
So I agree with you. The metal does not serve a function once the bone has healed. So if I'm correct in understanding you, you're doing poke hole, which we would call percutaneous Shannon Burr osteotomy, both Aiken and at the first metatarsal neck, and you're translating the first metatarsal head laterally. Is that correct?
That's correct. But
And then, yep.
I have my certain cut, which from the midline of the surgical neck of the first metatarsal, my cut goes distal dorsal at 45 degrees from the
Mm-hmm.
midline, and then 90 degrees plantar from the midline. I shift laterally,
Mm-hmm.
and the way I splint it, it keeps it in position. So they're ambulating. It's not that fragment can't plantar flex.
Mm-hmm.
And because of the 45-degree shelf that I make, even though they're ambulating, that fragment can't dorsiflex. So
Mm-hmm.
I don't worry about that. I've never had a problem with sesamoids. I've just I get very few problems, if any.
How often are you doing the Aiken? Are you doing an Aiken every single time? Or is it just you do the first metatarsal osteotomy and then you evaluate and see if you need the Aiken?
Usually, usually I'll do the first metatarsal osteotomy and see how things align. Sometimes I only have to do a tendon release, or it just aligns so well that the Aiken's not necessary. But in the more severe cases, of course, the Aiken is most notably necessary.
Is there any amount of deformity that you can't tackle with this osteotomy, is there a limit to the severity of the first intermetatarsal angle that makes this not viable?
It's got to be really severe. I saw one recently, and it was so dislocated, and so were the smaller MPJs, and it was out of my hands. They needed a 4 foot reconstruction, but most people that I train have traditionally been trained with a procedure called the Reardon Isham procedure, which is a
Mhm,
very good MIS bunionectomy correction. Uh, it'll work to mild to moderate bunions, but in with my technique, I can do mild to severe
mhm,
with good results.
sure. Um, how often are you getting non-union? I mean, are you seeing non-union? Are you seeing, like, everyone has complications. What how often are we getting something where we're like, "Okay, well, you have to go in and do something different or modify it or anything," or is the fact that you're taping it and the fact that the bone apposition, just like a fracture should heal, not really causing any issues?
Well, most importantly, especially with the handpieces and consoles, you want low speed, high torque. You don't want to burn that bone
Hmm.
because that's typically what can create a non-union. I personally, perhaps it's just luck, I don't really see non-unions. I'm more apt to see a non-union in a Taylor's bunion correction.
Okay, that's interesting. I mean, obviously, the first metatarsal has good blood supply, and when I'd see people for first metatarsal fractures, I can't think of one that didn't heal because it does have good blood supply. So as long as you don't, I guess the only thing that comes to my head is some people, even though I get into arguments, but some people advocate for 100% translation of the first metatarsal head on the shaft, which means there's no bony apposition. Now they're holding it together with metal. How far are you aiming to translate that capital fragment because there is no fixation?
Anywhere from 25 to 50%. There's one MIS technique called the Bosch procedure where they're pushing it over 95% and they're putting in a K wire. To me, it looks like that fragment's gonna tip over, like
Hmm.
fall off a cliff.
Right.
So to me, that doesn't make a lot of sense. But you'd really be surprised how little of moving that fragment laterally you need for very good correction. You're
Once
also reducing the medial eminence, and that's a big part of it, obviously, as well.
Yeah, so that's kind of where I was going next. So you've made your osteotomy, you've translated the capital fragment laterally 25 to 50%, maybe up, maybe a little bit more. And then are you taking that burr and shaving the residual first metatarsal bone of where your osteotomy was made? Because sometimes that can cause a little bit of irritation.
Okay, so I only shave in the morning before my showers. I never shave at my clinic. What I do is I actually reduce the medial eminence. That's the first part of the procedure
Hmm.
because the first metatarsal, if I do the first metatarsal osteotomy, that fragment becomes unstable. I need it to be stable to
Right.
reduce it. So,
Hmm.
what I like to do in my head is try and follow the medial shaft of the first metatarsal distal. And that's how much correction I want. That's how much medial eminence I want off. So
Sure.
I'll cut through it. I obviously move the capsule out of the way. I underscore it, and then I'll use a Shannon 44 first to debride some of the cortex, and then I'll use a different burr. I call it a Christmas tree because it's wider than a Shannon 44. It's a 4.1
Hmm.
millimeter burr, and I reduce the medial eminence until I'm satisfied that I'm where I should be according to the medial shaft. And of course, now I wasn't trained with fluoroscopy, but now, of course, there's fluoroscopy, and I can always check the precision. But
Mhm.
I've been doing it a long time, and a lot of it is very tactile.
Yeah, I would agree with that. When I do any minimally invasive surgery, whether it be a Lapidus procedure or some sort of fusion, like a hindfoot fusion, it is very tactile. I'm listening and I'm feeling. And some of that, not some, a lot of that comes with experience. What would be your recommendations for someone who has never utilized a Shannon burr, an MIS burr, and is interested in trying these procedures? Cadaver lab, obviously, sawbones maybe with less of, sawbones aren't exactly comparable to humans, obviously. So, what would be your recommendation for someone who's trying to learn this and get a feel for how it should feel?
I teach in the cadaver labs at least once a month,
Hmm.
and we get people that return every cadaver lab, and we get some people who are very interested in learning MIS. And I advocate that they learn the simple procedures first, like maybe a condylectomy of the digit,
Sure.
reduction of an exostosis, perhaps some tendon work, just to get a feel for the instrumentation and the anatomy. I don't expect these people to try and correct a bunion immediately and then go to their clinic on Monday and attempt to do a bunion. I mean, that's
Right.
certainly takes a lot, like anything in life. It takes experience. There's a learning curve, practice. We learned to ride our two-wheel bikes. We had training wheels first. We crawled before we walked. And it's the same with MIS. It may look easy. We may make it sound easy, but it takes a lot of practice and a learning curve. And even myself, I tell the people I teach, every time I do a bunion correction, it feels like a new experience to me. And all I do in my particular practice is from the head of the metatarsals distal. I don't, and that doesn't include fungal nails or plantar's warts, ingrown toenails, etc. So I've had a lot of practice with it, and I advocate to my students that they've got to get a feel for the instrumentation and the techniques and move forward from there. But
Hmm.
cadaver, I don't love sawbones, but it's a way we always use to start things off. And everybody that comes has their own cadaver, and a lot of the cadaver labs that I teach at take place in Chicago by the American College of Podiatric Physicians and Surgeons. And we have one-on-one instruction, which I think is invaluable. And they get a feel for things.
Yeah, absolutely. I think the benefit of sawbones is that you can see pretty clearly what you're doing. And if it's the very first time you're holding a burr, you can see your angle of how you hold your hand affects the angle of the osteotomy or the angle of the bone. And you can then translate the capital fragment. And you realize pretty quickly that the angle and how you're holding your hand has a significant relationship to the translation of the capital fragment. When you're not able to see inside because you're doing it percutaneously, even if you're using fluoroscopy to assist you, it doesn't take much of an angle deviation for you to either lengthen the first metatarsal, shorten the metatarsal, or not have a true osteotomy where your capital fragment is moving exactly how you intend it to. So I think the benefit of the sawbones initially is there, but then moving to cadavers makes a lot of sense because you get a feel for how actual bone feels when you cut through it, and then manually manipulating it percutaneously, like you said.
Correct. And there's some wonderful facilities out there for training individuals. And the beauty of it is we have fluoroscopy at all these cadaver labs, so individuals can see what they're doing.
Yeah, so how does that work? If someone was interested in in the training and the courses that you're talking about? Do they sign up through the website like you mentioned, the American College, or how do they get involved in that?
There's uh, two associations that put on cadaver labs. One is the American College of Podiatric Physicians and Surgeons, and they generally put it on small group cadaver labs every couple months.
Hmm.
The other association is the Academy of Minimally Invasive Foot and Ankle Surgery. They'll put on a big one in February, and this year it's in Orlando. Plus, they also do some master classes or classes for fellows, the more experienced individuals, usually at the medical school in New Orleans.
I see. What would be your tips for techniques? You might just say, well, come to the course and I'll show you the techniques. But if you could give just some broad aspects of, do you use any, are you flushing it when you use your burr? Some people advocate that you need to flush with saline when you do a burr. I don't use it. And then the flip side, which maybe you'll mention, is if you're not using a tourniquet, then the bleeding is cooling the burr. But what are your thoughts on that?
Absolutely. I tell my students if they make that poke and blood isn't coming out of that poke, you got to poke something else. Blood has to come out.
Yeah.
In other words, to get the bone fragment to come out with the blood. Of course, we rasp everything and we flush it. Um, I usually flush with Marcaine, or you can use saline, whatever you feel comfortable with. But
Hmm.
the beauty about what I call the real minimally invasive procedures is that it's flexible and it's forgiving. So if you put that hardware in there, and I see lots of patients that come in that have had the hardware, they've had their procedures done by the socialized hospital, socialized medicine in the hospital. Sometimes when they have the hardware there, I can't do a correction. I can't do a tweak. I can't repair something because all that metal's in the way.
Hmm.
But
What's
using external fixation, you can tweak anything.
right? So, do you have any other techniques for, how you hold your hand? One thing that comes to my mind is if you're operating on someone's right foot, you're using your right hand. But if you're operating on their left foot, then it makes sense that you may have to use your left hand. How do you orient yourself, or can you use either hand?
Well, I'm not ambidextrous, but I use my right hand.
Yeah.
And to me, it doesn't matter. It's just the way I stand for all my procedures.
Okay.
So yeah, I move myself wherever I have to be, and there's nothing to really think about.
Yeah.
And I don't use one of those standardized fluoroscopy units, those huge units that are on all the time. I have a handheld fluoroscopy unit, and
Hmm.
when I need to use it, I just lift it, hold it, and I have monitors all over my surgical suite. I
Hmm.
also have a small monitor for the patient to watch, and they love it. They can't
Hmm.
believe their eyes what I'm looking at.
Yeah, that's kind of a a leap there from our healthcare system when we're doing surgery on people. I mean, I do in-office procedures, ingrown nails, and little excision of lesions and biopsies and things like that, but not true bone work. So the patient is obviously awake. Have you had any issues with the patients being awake and not tolerating the sound or the sight of blood? Do you block their field, or how does that field of vision? I mean, so they can't see what's going on, or how does that work?
Well, we have a Mayo block that we put in front of them, and they
Uh-huh.
say, a lot of patients will say, "Oh, I want to watch." So my typical answer is, no, I can't let you watch because I don't want you to learn this procedure and then you're going to do it on your friends and relatives and I won't have a job. And I have one of my assistants standing right next to the patient at all times,
Uh-huh.
and we call it talkesthesia, where my assistants are all very charismatic, very caring. They're very friendly, and it's all honest, and they chat the patient up.
Sure.
And I also, if I prefer it, but I typically will give them a sublingual Ativan
Okay.
to bring their anxiety level down. Because let's face it, a lot of people are quite anxious about it,
Sure. Sure.
and this brings their anxiety level down. But I have an assistant next to them. Should they start losing color or say, I'm feeling hot or lightheaded, we
Hmm.
have a button on our surgical bed that tilts it into the supine position, and we have cold compress. We have the smelling salts, and we don't have a problem.
Yeah.
Thank goodness we've never lost one. And one of the original pioneers in MIS once said, a patient will never die in your chair. They've got so much adrenaline running through them, it's impossible for them to die.
Yeah. Makes sense. Well, and the likelihood of them dying would not be from, fright, or if they faint or something like that. Maybe they'd have a reaction to lidocaine or marcaine or something, but that would be highly unusual. Are you operating on lesser toes, like hammer toes?
Absolutely.
And so what's your
So
technique? Yeah.
anything distal to the metatarsal head.
Okay, so what's your technique? Let's say someone comes in with a pretty moderate bunion. I already know how you're going to fix that. And they come in with maybe a pretty significant second hammer toe and a mild third hammer toe. What is your approach for the lesser toes?
If they're rigid, the first thing chances are I want to do is a flexor and extensor tenotomy. Because if you do an osteotomy on the proximal phalanx of the lesser digit and one of those tendons is pulling or over pulling,
Uh-huh.
you're going to have a problem later on. So typically, what we do in MIS is we do a proximal phalanx base osteotomy. So it's situated just distal to the base of the proximal phalanx
Uh-huh.
through and through osteotomy. Now we can wedge it. So if the toe is overlapping the hallux headed medially, we can wedge it and make the osteotomy with the apex medially and the
Hmm.
opening laterally to wedge it over once it straightens. Sometimes, even after we've aligned the digit, there's an enlarged head of the proximal phalanx, at which point, through the same incision or poke, I'll go in and I'll reduce some of the head of the proximal phalanx, condylectomy.
Hmm.
And once I'm satisfied with it, that's fine.
Hmm. I
It's a
assume,
it's a simple procedure.
yeah. I assume I know the answer, but also no K wire, no fixation in there. You're just using your, is it tape, or what are you putting on after the procedure? What are you using?
It's tape. It's usually cloth tape, which is has a very high tensile strength,
Hmm.
and then I'll wrap over it with Coben or Coflex.
And how
But
long do you
it's rigid.
yeah, how
So
long do you leave that intact?
for a bunion, it's 6 weeks. Some of my colleagues take them out of the splint in 4 weeks. I don't feel comfortable with that. I like the 6 weeks. And for a hammer toe, typically 3 or 4 weeks of bandaging. That's it.
Are you leaving it on that whole time, or are you having them come in and change the bandage, looking at the, I call it incision, but poke holes, and then reapplying tape thereafter?
I do it weekly
Okay.
because I encourage them to walk as
Mhm.
much as they can.
Mhm.
That splinting can loosen during the week.
Okay,
So I
sure.
ask them to come in once a week for a fresh, clean, secure bandage so I know that it's externally fixated properly.
How much pain do they complain about? I know you said you don't give any narcotic pain medications, which I think is fantastic. How much pain do they complain about after the procedure? Are they limping? Are they using crutches? Are they able to ambulate in the post-op shoe pretty okay?
They do wonderful. Like I said, we expect pain. I mean, there isn't a procedure on one's body that's performed that you shouldn't expect any degree of discomfort.
Right.
But like I tell them, that we have them doing ice and elevation for the first 48 hours and limiting their ambulation. But I tell them if in the first few days you have some discomfort, it's typically because of the swelling. Use your ice,
Mhm.
elevate, and if you need something for pain, Advil, Aleve, Tylenol work fine. Trust me, we're all different and both
Yeah.
feet are different. And some of my patients maybe take one Advil throughout the whole healing process. People don't like to take medication. I don't know if you've realized that lately,
Some people
but
do.
my
Some people take
yeah, and
too much, but most
yeah,
reasonable people don't.
they love the narcotics, but for my patients, I tell them before the procedure and through the healing process, take something called arnica,
Mhm.
which helps with reduced swelling and bruising, etc.,
Mhm.
or turmeric or whatever.
Yeah.
And yeah, most people just they tell me I don't want to take any pills. I don't like taking pills.
Uh-huh.
Well, sometimes you have to.
Yeah, for sure. What would you say how often do you have to revise something? In the back of my head, I think maybe in America we're over pro over weight bearing protecting people, which means we do surgery, we put metal in there, and we put them in a boot or a cast or a splint and tell them to use a knee scooter and crutches, say, "Don't walk on this, don't walk on this, don't walk on this." And that's probably overkill. Um, I don't know. So, I assume
That's
that the
when you were trained in your residency for that stuff.
yeah.
In the residency, they never mentioned MIS, but trust me, it's a viable alternative.
No, I think it is, and I think it's very reasonable. And I think it's very interesting to not use any hardware. But it makes me, just based on seeing my own patients, makes me nervous because I've had people walk on surgeries that I've done, not necessarily a head procedure of a bunion, but certain other procedures, and they've messed it up, or the screw's broken, or the osteotomy failed, or something happened. What How do you tackle that? Because I think that's inevitable because some people have diabetes, some people smoke, some people did too much on their foot when you said walk a little and they went to Disney World or something. So how do you handle the cases where things maybe are slow to heal or don't heal like you want?
I'm being perfectly honest and transparent. Either there's some skill involved or I'm just one lucky individual. I don't really have to deal with those types of complications. I also use something here in my clinic that I invented, developed, had made in Germany, and I use it for a lot of things, but I also use it post-operatively. And what it is it's a plate of 64 low-level lasers of two different wavelengths, and it's surrounded by a ring of pulsed electromagnetic therapy. It's a
Hmm.
20-minute treatment. It doesn't hurt. You don't need anybody to administer the treatment. There are no side effects. You just don't want to do it on somebody that has a pacemaker. And I use it a lot for post op, and it really, really helps with healing and edema, etc.
Hmm.
And to be perfectly honest, I don't deal with a lot of the difficulties I hear with people who do hospital-based procedures. Because I know that screws can break and plates can break, and you deal with sesamoid problems, and the list goes on.
Yeah.
I feel lucky or blessed that I don't have to deal with that, and I'm being transparent.
Do you think that you have a fairly healthy population? Is it a self-selecting population who's choosing to go outside of the I forget what you called it, but the typical Canadian
Socialized
healthcare?
medicine.
Yeah, that go out of that. Do you think that's maybe a self-selecting population that might be a little healthier, or do you get kind of broad ranges of people with all kinds of health issues?
Well, we only accept patients that call that would like their bunion corrected or their hammer toes, etc.
Hmm.
If they call with an ingrown toenail or something else, we have colleagues we refer out to.
Hmm.
But I get a wide range of age groups and men, women, etc. Currently, believe it or not, I have a 2-year consultation waiting list.
That's great.
I don't like that people have to wait, but their only alternative is to have it done the traditional hospital-based socialized medicine way.
Hmm.
And they've heard from their friends, colleagues, coworkers, neighbors, relatives, the difficulties that they had having it done, and they don't want it. People don't want to take narcotics. They don't want general anesthesia. They don't want metal in their foot. They want an alternative. And
Yeah.
if they find me on my website or whatever, or they have patient referral or family doctor referral. I had a referral this week from an orthopedic surgeon from the hospital. He said, I'm so busy doing repairs on pickleball Achilles tendon injuries, I can't do a bunion. So I
Yeah.
want you to go see the Bunion King.
Yeah.
Um, they've heard the stories, and they don't want it that way.
How do you decide what to charge? Because in America, we're very driven based on this is the procedure code, this is the CPT code. You submit it to whatever their insurance might be, and we're beholden to that insurance company to get that amount of money. Certain private insurers pay more than government programs, and you're kind of stuck accepting whatever that fee may be. How do you decide what to charge for a certain procedure? How does that work?
Well, as you know, I spend a lot of time in the US and with podiatrists, and I've heard the insurance horror stories, the copays, deductibles, predetermination. And I mean, if you take a patient to the hospital for a bunion correction, if you're lucky on a good day and 4 hours out of your day, you might get 450 or $650. That's what we charge for orthotics here.
Hmm.
So because we're not regulated, we can charge whatever fee we like. And in my particular practice, it's all cash pay. I have no accounts receivable,
Hmm.
and my fees are quite high.
And because people are able to access you outside of the typical healthcare system, they're willing to make that payment because you can get them in sooner, maybe. I don't know. It sounds like you have a long wait list, but I know socialized medicine has potentially a long wait list. But is that why people are willing to do that?
No, they don't want to go through, as I said, the general
Yeah,
anesthesia, the
sure.
scars, the metal implants, the narcotics, the opioids, uh, extensive time off work.
Yeah,
They don't want that.
sure.
They want to get on with their life. And that's the beauty of these particular procedures. You resume your life.
Absolutely.
And pretty much about 95% of my patients that have bilateral bunions have them corrected a week apart.
Hmm. Interesting. That would be very unusual in America with the way that we typically fix bunions would be unusual to do it that close together. So it sounds like a fantastic procedure for these people. So if anyone was interested in kind of checking out where you are or how to get a hold of you or go to one of these courses, what would be the step for them to do that?
I would probably start with the American College of Podiatric Physicians and Surgeons website, and they'll list their upcoming events. And again, the other one is the Academy of Minimally Invasive Foot and Ankle Surgery.
Mhm.
Those are the two of two of the associations that really hold a lot of cadaver courses,
So they
especially the American College. Every 2 months, there's a very small group, which is really nice because we have one on one instruction and
mhm.
everybody has a cadaver to practice on.
So they can go to that website, get more information about upcoming courses.
Yes, I would start there.
Absolutely. Well, I want to thank you for joining me tonight. I appreciate your time.
It's been an absolute pleasure. Thank you for
Absolutely.
having me.
So if people are interested in checking you out, you're the Bunion King. The Bunion King's available on Instagram, TikTok, YouTube, all over.
Right.
All right. Well, we'll send people your way. I appreciate your time.
Thank you so much.
Absolutely. Thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.